So there is change in sequence. Dr. Amit Raj, who is the professor and head of the Department of Ophthalmology, AIMS Patna, has to leave for another session. So Dr. Amit Raj will come for his presentation on managing cataract in post-intravitreal injection patients.
Last one. Yes, this one.
Nowadays, a lot of intravitreal injections of anti-VEGFs are being given right from periphery to big hospitals, and these patients can have cataract also because of that. So he is going to discuss that.
At the outset, I am thankful to Chief Instructor of this session, Dr. Subhas sir, for making me part of this instruction course. So, coming to the topic, as intravitreal injection is especially anti-VEGF is being used frequently as in different types of retinal vascular lesions. There is price initially patient pays, and if complication occurs, then again he has to pay that price second time, but again it gives more stress to the surgeon. So this intravitreal injection has surpassed the cataract surgery in US. You imagine the number of injection is being given, and it's in different study its incidence is around 0.44 to 0.6%. So what complication can occur with any intravitreal injection, right from simple subconjunctival hemorrhage at the site of injection to raised IOP, to a dreaded vitreous hemorrhage, retinal detachment, endophthalmitis, and CRO. But cataract is not very frequently reported, so I searched the literature, and one of the study done by Moorfield Eye Hospital in 12 to 15, and they have included around 63,000 cases of cataract surgery, out of which there was 1.64% intravitreal injection was given, and PCR occurred in 1.04%. But after logistic regression, it was found that there was increased risk of PCR in cases where intravitreal injection was given. Another study, in this study again complication rate of PCR was studied. So out of 10,327 cataract surgery, there was 2.6% PCR in patient who has received anti-VEGF, while only 0.5% PCR occurred in rest of the cases. So what is the main reason of this cataract formation? There may be faulty technique. The patient may be very uncooperative during injection, maybe due to pain, or patient is just not cooperative for the procedure. There may be jonular trauma, either there may be direct jonular trauma, or due to deformation of the globe there may be jonular trauma. There may be direct, if you are not going to the proper site of injection, then one can directly injure the posterior capsule. And again, in type of injection, mostly anti-VEGF is being given, but when you are using IVTA, intravitreal triamcinolone, or dexamethasone, chances of cataract formation is high. So what precaution one should take while giving anti-VEGF? First, one should know the phakic status, whether patient is phakic, pseudophakic, or aphakic. Then question comes, what is the preferred site of injection? One should go for 4 millimeter away from the limbus in phakic. In pseudophakic and aphakic, one should go for 3 to 3.5 millimeter. Inferotemporal quadrant is the preferred site, but one can go to a superiotemporal, and lastly one can should go for superionasal, but one should avoid inferonasal quadrant. Regarding the gauge of needle, ideally higher the gauge, lesser will be the pain, lesser is the chances. And again, length of the needle is important, 0.5 inch to 0.62 inch is should be the length of the needle, and direction should be, of the needle should be towards the center of the globe, and speed of injection should be moderately slow, otherwise there is chances of detachment of the needle from the main injection, and it can again injure the posterior capsule. So there is no alternative of thorough history in these cases like any other cases, but there are some clinical cues. When you go for slit lamp examination, there may be needle track injury, and one can suspect then there will be chances of PC defect. But in mature cases, when cataract is so much there, you will not be able to see the posterior capsule. So one can see the wrinkling on the surface of the capsule. In these cases, when there is history of anti-VEGF, there is some clinical clue, one should always take help from the different modalities like UBM, B scan, anterior segment OCT, and sign plug imaging. So one can clearly see the defect in the PC. So in a study, it was found that which instrument it gives better insight into the defect of the posterior capsule. So it was found that UBM has more sensitivity and specificity compared to anterior segment OCT and sign plug imaging. Again, accuracy rate is also high with UBM. So when you have come across a case of cataract who had chances of PCR, pre-existing PCR, so how you will manage? So why it is important? Because there is chances of nucleus drop when you are not taking precaution. So VR setup should be ready for that, and these cases should be done under perivalvular anesthesia. Another most important thing is one should counsel the patient and attendant about the risk in these cases. So these cases should be managed like posterior polar cataract. So like posterior polar cataract, one should avoid hydrodissection. Parameter should be low. Bottle height should be low. So after removal of the initial central part of the nucleus, one can see at this stage PCR was detected. So before removing the aspiration cannula, one should form the anterior chamber so that PCR should not increase, and it is individual choice. One can go from limbal route for anterior vitrectomy, and if you have access to trocar, and one can go through the posterior route. But in different study, it has been found that by posterior route, vitreous clearing is better compared to anterior route. Three-piece lens in these cases is desirable because and one can go for optic capture also for better stability, and after that tricoat is injected to see any vitreous tag, and again vitrectomy should be done. So to summarize, large number of patients are benefiting from intravitreal injection. Adequate precautions should be taken while giving intravitreal injection. A small percent of them may end up with iatrogenic capsular damage and traumatic cataract. Preoperative use of imaging modality can be very useful to detect or confirm PC defect. Meticulous pre-op evaluation and proper surgical approach enhances surgical result in these cases. Thank you very much for present hearing.
Thank you, Dr. Amit Raj. Any question from the audience?
Related to this?
The one comment very important, he has said that you have to have a very high index of suspicion in any patients who come with rapid progression or rapid onset of cataract and who have undergone intravitreal injections. So generally what happens that these patients who are undergoing treatment for the vascular disorders, they have very poor vision or very less vision. So they may not report you so early, but whenever they come and they say that I am having further decrease in vision after the injection, then you suspect cataract and you dilate it properly and try to see any track of needle injury. If it is not, then if the cataract is very progressing very fast or it's total, then other modalities really help. And again, he well said that managing these cases like posterior polar cataract is very important.
Uncontrolled long-standing diabetes with a history of DME, with a history of having this anti-VEGF injection, preoperatively would you prepare any differently from the regular cases which were not so much long-standing diabetes?
Yes, if there is a clue, especially in other eye, there is a CSME, so one should go for at the time of after completion of surgery, one can go for intravitreal injection, or you may go for 1 week before the surgery. But problem is that you have to take patient for 2 times in the OR. So better to give simultaneous injection at the time of surgery.
At the time.
After completion of cataract, one can give injection of
on the same table,
whatever ranibizumab, eccentrics like.
Suppose we are planning for first intravitreal and then cataract surgery. So how many days should be there?
Ideally, one should give 1 week before for better effect, or one can give go for 1 month before. But in different study, it has been found that if you are giving simultaneous injection, effect is good.
After how much time should we suspect that this cataract is because of injection? See, today he has given injection after 1 week or 10 days.
Yes, generally there is fast progression, but most of the cataract develops within 1 year. Within 1 year. Although whenever you are giving injection, one should examine after next day, 1 week, then after 1 month.
No, but if it is a faulty technique, it can just happen in a week or 10 days, whatever. If it is a faulty technique and it has really
It may develop, but generally within 1 year cataract.
But no, but I would like to intervene here. The cataract can be because of the as such multiple injections are known to predispose for more cataract, but that will not lead to such kind of cataract. If it is because of touch, then it will be almost immediate, and it may progress or may not progress. In some cases, it gets plucked because of the solid vitreous. Sometimes it gets plucked, so it doesn't progress. But in some cases where the injury has been bigger, like in Ojudex, I have seen 2-3 patients of Ojudex coming immediately at next day with huge, with you can say very progressive kind of cataract. So depends on the contact and needle and also pre-existing cataract also. And if the patient's diabetes is not also well controlled, then these patients are landing with very rapid progression of cataract.
So how much time
early.
should we wait? Today you have given Osudex and we detect the cataract in a week. So how much time should we wait to do the cataract surgery?
Cataract surgery, in my opinion, it should be done as early as possible because it's going to
Even if
progress
it is
very
few
fast.
days
Yeah.
before
If the cataract is very early, then you can very well see the posterior capsule margin and can manage it nicely. But if it has progressed too much, then there are more chances of complications, more chances of nucleus dropping into the vitreous. So it should be done as early as possible.
If it is diagnosed early, then naturally it is okay. But in longer standing cases, one advantage is that there is fibrosis of the posterior capsule, so it will not enlarge. in longer standing cases, one of the advantage. But when you are diagnosed early, a patient has problem with cataract, so one should go for surgery.
Thank you, Dr.